Good day. I'm Michael Bendner from the Center for Fiscal Equity. Um, this video is for staff and members regarding the Hospital Insurance Trust Fund and future Medicare financing hearing before the Senate Finance Committee Fiscal Responsibility and Economic Growth Subcommittee. So it's the Hospital Trust Fund, also known as Medicare Part A, even though it has no cap, is funded by a payroll tax that leaves non-wage income off the table. For the top 4% of taxpayers who are half and half, meaning half of their income is asset-based, and half is wages. And a lot of that wage income, frankly, is people who are celebrities. Generally, most CEOs and managers, take only assets. It's the celebrities that take the multi-billion-dollar salaries. Athletes, recording artists. They're responsible for the high wage part of this mostly. It's for most people. It's capital that funds them, and that does not get touched by HI. The other 96, their biggest piece is wages, and so they pay more. So it's still aggressive, and it's endemically close to falling below revenue because salaries have taken a dive, and capital rewards have gone up with time. So now you could fund payroll HI forever if you raise it to the HI payroll tax to 5%, but for some that would be a burden, and it leaves too much AGI on the table, like $4 trillion of AGI is left on the table, more probably because some of AGI is offset by losses. The AGI formula is a little funny, and Tax Policy Center did a piece on that just very recently. Among the elderly and severely disabled, there's a constant battle between nursing homes and hospitals for cost avoidance, and the patients are in the middle. In other words, people say, "Oh, let's send you to the hospital," and then they say, "Okay, you're fine. Let's go back to the nursing home," because one gets HI, the other one doesn't. And healthcare suffers. There's certainly more to be said, but I count on the listed witnesses to say it. I'm sure that some of them have interesting proposals for the reform. I have my own. HI cannot be treated as one component without affecting all of the components of healthcare. This is especially the case if some form of single-payer system is inevitable, and it is. Whether you call the public option expanded Medicare or the real thing, the entire system is in need of change. And so you can't, we've got to come out and take a longer look, a wider look on changing everything if you change HI. So I talk more about that in the second part. So please see part 2. There's a link to it down below. And it will be also linked to in my submission to committee staff. I thank you very much. Just to briefly go into it, the profit motive for the public option, will cut costs, and if combined with, and it should be combined with, to pass an end of pre-existing condition reform, so that they can deny coverage and erode people into the public option. Eventually, it's going to be single payer, and the same providers provided anyway. It's seamless. It wasn't my case. I'm disabled, and I went from Medicaid, and then Medicaid for 2. Then after I got my SSDI, Medicaid for another 2 years, and then Medicare, and a lot of things changed. But it was Kaiser the whole time. Except for certain mental health care expenses. The main health care was with one with one provider, and they had a variety of billing systems, and that's unfair to the providers. So, and it eventually works out the same in the end, and it doesn't make any sense. So, but I'll talk about more of that, and also the budget consequences of the way we're doing it, and and the way we're taxing capital returns and capital gains, and why that's important, and why it shouldn't be something that we do for healthcare, but other kinds of consumption taxes should carry into that. And I'm now stepping on my other video, so I will say thank you very much. Please see part 2, and also other attachments that even discuss this even more.